All right, this complete all the talks for today and for the whole symposium. I want to thank Jenna for showing that video. What a great video to remind us. One day we can probably shake hands again with the patients. And also remind me that we will go back to work tomorrow. All right, so now we are ahead of time. We'll open up the session for Q&A. I think we have one question on the online from the Zoom users. So I guess, so the question is, for injection of nanoparticles into tumors, what clinical specialties do you anticipate will be involved? Interventional radiology, surgical oncology, or a new distinct specialty? I think my thinking, I mean, I'll have all the other physicians to chip in, but I think just based on the radioisotope like practice we used to do, I think just a nurse with the biosafety training should be able to, but wondering whether Dr. Ink has more comments.
So,
yeah, if you can hold it.
So generally it was developed a protocol for this intratumoral injections of the hafnium oxide. So it's even not injection, it's a special number of needles. And the volume is calculated on the volume of the tumor. Typically it's required 10% of tumor volume for the injection. So, and it's done simultaneously in the several spots on the tumor area. And generally, I agree with you that it can be done by the nurse. But before that, it's still image guided kind of, verification of the margins.
Sure. All right. Anyone has some questions in the room? Yes, Dr. Ink.
Well, for Jana, I was going to say we might even want to upgrade that since we've changed the technique quite a bit. So they no longer have the hot water bath to soften the aquaplast. They just use heated air, so that's different. And I thought it was actually really interesting, Jana, with the talk you did and the one that we heard from University of Texas Southwestern this morning, where they were actually kind of having the kids able to watch video clips. And I was even thinking about that even in conjunction with fatigue. And, are there things that could be done with virtual presentations for patients to maybe address issues on fatigue? And the other one I was thinking about with the virtual reality was, Megan, what you were talking about yesterday in terms of patient education and again, kind of the power. And I think you could do it without doing that, but it's multiple variations on the same theme that the visual can be really helpful for probably conveying information.
Yeah, I think Jana should weigh in on this as well, but something I wanted to mention is that, there's been clinical trials from San Diego that show that consultations with physicists can help reduce patient anxiety as well. So something that would be interesting is to see, what's the difference in the benefits in terms of anxiety between doing video education like this versus adding other members of the clinical care team to that communication piece. And can some combination of those two things maybe increase that benefit even further?
Following the same line, I think I would like all my patients, when they are waiting for me to see them, probably just, let them watch those things for 5 minutes and each site. So they will be, when you walk in, they will be very happy, not that nervous anymore. So they don't feel like waiting for you. They have something to do.
That's a good idea. We should probably just provide the iPad to all those people to watch it. I think the question, also have a question for Jenna. I think I would like to hear your input as well. But so are all our patients eligible to go see, like, to participate in this kind of virtual program? Or are you guys have some selections? Do you have selections? Or you can push the button.
Oh, I'm having a hard time hearing what you're asking me.
Oh, I'm sorry. My question for you is, are all the patients in our department eligible for doing that? Or do you guys select certain patient that, for example, high anxiety patient?
I'm sorry, I still think.
Yes. Okay. So I guess we can universally provide the video to them then.
Be helpful to randomize like we did with the head and neck and just see which, who benefits.
That's true. So I do have oh yes, Dr. Zhang.
Just a quick question. Before I say that, I have to say though, thank you, Jenna, for showing the best looking radiation oncologist in our department, head and neck radiation oncologist. So my question about the nano medicine actually was very intriguing and very interesting. So my question is that one of the materials that was used as radiation sensitizer is high Z material. Now, is that specifically or preferably picked up by the tumor or also by the normal tissues?
So I think that the whole trick that this is kind of neoadjuvant setting. So they use the nanoparticles to enhance the dose of the radiotherapy, particularly in the tumor. And after this treatment, it will be resected.
Can you press hard and hold on to it?
That's what I did. I think that the major trick is that you more like equally or homogeneously inject these particles into the tumor, right? So, and that's what was important before they even moved to the clinical application, to show that during the therapy and after that, you don't have too much, practically minimal leakage of the hafnium into the stream. And after that, they do the resection of the tumor. And that's how they assess the actual response to the treatment.
So there has to be, a tumor has to be accessible for the injection, is that correct?
Oh yeah, yes. That's why it's not like a overall applicability.
All right, in that case, let me ask you a follow-up question. So if you want to improve the targeting capability of those nanoparticles, I see a lot of antibody-coated nanoparticles, but in that case, would the body start to develop to be immune to those foreign objects? I mean, that's limiting the chance of repeating the injection.
So eventually, yes, especially if you use like a protein-based, peptide-based targeting. So, and like I tried to mention, as soon as you put the additional layer of the complexity, you put additional challenges on the, especially systemic delivery. That's why till to now, there is several clinical trials with the actively targeted nanoconstruct, right? But neither is, get any approval or show some kind of improved efficacy.
All right, I do have another question for Dr. Dickinson. So to me, when I was listening to the talk, my feeling is, I think fatigue is more a physiological term or phenomena. But how do you distinguish this from psychological issues? For example, depression, which a lot of times can cause that too. And Or is that the same thing that you want to study in terms of mitochondrial genetic profiles?
So that's a good question. A lot of times symptoms tend to cluster in patients. So we see a symptom cluster of, say, pain, depression, anxiety, and fatigue. And a lot of people think that fatigue is a maybe subset of depression for a lot of patients. But we have shown some evidence that fatigue doesn't trend the same as depression, so it is a distinct symptom for these patients. I think that was to answer one of your questions. And then in terms of, so we have, and then that's why when I conduct the studies, we aren't just looking at fatigue in isolation, we're also looking at their depression, anxiety. So when we look at the biomarkers and the fatigue, we can also look at for those covariates of depression, anxiety, physical activity, things like that to see what how it influences the markers that we're looking at.
So in that case, how do you tell a mice with ADT is fatigued or depressed?
So in terms of the mice, that's why we're running them on the mice naturally like to run on these running wheels. So we have a healthy control group of mice too that we're going to run through running wheels that we're currently running right now, and we're measuring the level that they run. Since mice naturally like to run, what we're expected to see and what prior labs have shown is a big drop in their willingness to run on the running wheels as an exhibitor of fatigue. So they don't run as much as the mice that aren't treated with the ADT or the radiation.
So
Did I answer your question?
yeah, I think that's kind. Do you monitor vital signs also?
I'm sorry, repeat that one more time.
Do you monitor the vital signs of those mice as well?
So we're not monitoring the vital signs, but we are looking at CBCs and specifically hemoglobin, just to make sure that anemia isn't the predominant reason that they're feeling the fatigue.
Okay. All right. Any other questions? Oh, good. More online questions. So I guess the question is for Jenna. As a hospital that's linked to UNMC via Epic, do they have access to Word? Or rather to Word database to utilize video for patient teaching?
I'm sorry, what was that again?
So for, I guess, practitioner outside our system, but linked to UNMC via Epic, do they have access to Word or like Word database to utilize video for patient teaching?
They would not, but you know, we're always looking to collaborate or find other ways to use it. So, I mean, that's not out of the question, but it's a secure system and it's just on our campus right now, so.
It's not directly linked to Epic.
I guess the answer for whoever cannot hear is no for now, but possibly in the future. All right, the next question from the Zoom user is, it's quite a long comments plus question. Research has shown that if the nanoparticle are not designed such that it's selectively absorbed by the tumor, the overall effect will be minimal, as it would just shift the therapeutic index to the right without widening the therapeutic window. How have you ensured that nanoparticle radiosensitizers is absorbed preferentially by the tumor? I think that's probably a question better for Dr. Brownish and maybe Dr. Garrison.
Yeah, and it's true, and not only in the relation to the radiotherapy. Yes, the major challenge right now, how to increase the sufficient dose of the active ingredient in the tumor using the nanoparticle delivery, right? So that's why the success, which we already see, it's not related to the systemic application of the nanoparticles, But like I mentioned, in terms of the hafnium oxide nanoparticles, it's an intratumoral injection. So in this case, you can achieve significant amount of material, which will enhance the action of the radiotherapy. From the other point of view, so the other method, how we can increase the accumulation of this construct in the tumor tissue compared to the normal. So, and in this particular way, it can be done maybe by designing different design of the particles, or like I mentioned, so by modulation, the microenvironment, the, of the tumor, just to kind of increase the accumulation of nanoparticles at the site of action, so which will widen the therapeutic index, because you can do this on the both sides, either by decreasing the toxicity or increasing the active dose of the treatment.
All right, there's definitely a lot of potential for nanomedicine. I have another question for Dr. Deegan. So in your study, when you show the enhanced effect when you combine the ADT with BMX drug, what do you think it's the underlying mechanism? Does the ADT decrease the superoxide dismutase? Or increase?
So that's a good question, and we don't know the exact mechanism. It has been shown that when you add testosterone, this causes oxidative stress in the tumor, and when you remove it, it causes an imbalance of the tumor redox status. So what we're thinking is occurring is that when you do both of these simultaneously, you're really basically interfering with that redox balance. And so we think we're causing a lot of oxidative stress in a very short period of time, and the cancer cell can't handle it. We don't know if that's the case, but there has been a couple of papers that have looked, and I believe it was copper zinc SOD, which is the cytoplasmic version, is altered with ADT therapy. And I believe catalase as well. And so there have been some reported literature that there is a connection there. We have not validated that in our system yet, so we don't know at this time.
Thank you. Anyone else? If no one else, I'm gonna just fire my question straight. So I do have a question for Dr. Garrison. Couldn't find him. Is he still here? Oh, I'm sorry. So what is the subcellular localization of the NTSR1? When you put the adduct on it, does that change the potential targeting?
So your question is, can you repeat your question one more time?
So because your target is, you're targeting the NTSR1, your design, molecular design is based on that.
Correct. That's on the outer surface of the cell. So
the
it's on
surface of the
yeah,
cell.
yeah. So when ligands generally bind to receptors, they get internalized, depending on if it's antagonistic or agonistic, and then they get delivered to the endolysosomal compartments. And generally, that's where they get the ligands or proteins or peptides get degraded. So the drug is binding to the receptor, and it's getting internalized into endolysosomal compartments, and it's forming the adducts in those compartments.
So in our case, what's the half-life of the lutetium? Like, although I'm a radiation oncologist, I can't remember.
The half-life of lutetium?
Of your isotope.
So the half-life is 6.7 days.
6 days, okay. I see. Yeah, and also in your study, you show that you can increase the tumor versus the kidney dose ratio to about 6 something. Is that based on the unit kilo or just based on the total organ dose?
So is it the 6.7 tumor to kidney dose ratios? That's based on the dosimetry, so the centigrade per millicurie. So the ratio between the tumor dose and the kidney dose.
What if you have very small kidney? Oh, a very small tumor. Would you still?
The size variability and how that may impact.
Yeah, would the size impact?
That's a good question. That's something I think we need to take a look at.
Right now, the Olinda calculations are based on like average human organ sizes. And so the next thing that we want to do is kind of separate out the mice by the different tumor sizes and organ sizes and take those effects into account. I think we will see some differences.
Great. All right, any other questions from the audience? So if no, I think I'm gonna ask the last question and then we'll call it the day. So, yes. So since we're so interested in fatigue, let me ask another fatigue question then. So I always hear patients saying, I think you alluded to that too. I hear people saying, I'm fatigued, I must be getting the right treatment. Is there any data really suggesting fatigue is a good, like a predicting marker for the good outcome of treatment then?
So that's a good question. We haven't really looked at that aspect of like the disease implications of fatigue, and that's something that we can definitely look at in our studies moving forward. I could see it both ways, where fatigue is the body's way of protecting itself as it's healing kind of from the effects of the treatment. So maybe it is a protective effect. But we haven't looked at that yet, but that's definitely something we can look at in the future. But that's a good point. The clinical outcomes, can you use fatigue and other symptoms to predict kind of clinical outcomes in this population?
All right, thank you. I think that's conclude our session. I'd like to thank the speaker again and bring up our Dr. Qiling, our Vice Chairman for Research, for the closing comments.
Thank you for hanging in here until the end of conference. And I think, yeah. Thank you. So, just hold on with me. People say it takes a village to raise a child. I say it takes a village to have a successful conference. Without 35 speakers, we won't be able to have this conference. I would like to thank all our speakers who spent time to prepare for their lectures and to come to this weekend symposium. I would like to thank all our moderators who have done a wonderful job to make the conference successful. I would also like to thank all the symposium committee members who work with me diligently throughout the year. This year's symposium, because of COVID-19, will be historical. You will probably never again have a conference that all the speakers have to wear a mask. I would like to have a special thanks to Lan Zhao, who is our PhD student in the department. Lan has been doing a wonderful job in the past 2 days to keep the slide upload and download process as smoothly as possible and to keep the desk of the podium disinfected, which is incredibly important during this special time. Next, I would like to acknowledge all sponsors, especially Varian, who provides an educational grant to support this conference. And we also have 1, 2, 3, 4, 5, 6, 7, 8 exhibitors. Last but not least, I would like to thank all audience from US and China. We have had 70 to 100 plus online audience, and 30 to 50 on-site audience each day. It is you that make this conference possible, so thank you. That will conclude the conference. Have a wonderful the rest of the weekend. Thank you.
What's that?
Why don't you put that